This is Dr. Mohammed Allo. Today we're going to be talking about stress testing. This comes up a lot. There's a lot of questions being asked about this. So it's very, very simple concept. The most important thing is that every stress test comes with three basic parts. There's an EKG portion that everybody gets. There's the actual stress portion of the test. And then there's imaging. Not all stress tests come with imaging, but some of them have to, and we'll go into all of these. So first of all, what is the point of a stress test? The point of a stress test is try to produce ischemia. We want to see if there's anything we can do to reproduce ischemia. And the point of a stress test is to find out if somebody has significant, stable coronary artery disease. Keep that in mind. It's significant, stable coronary artery disease. Now, significant is defined as usually lesions within your arteries that are about 450 or 60%. Now, remember, we don't stent anything unless it's over 70%. And the point of this whole test is to try to find out if there are any lesions of about 50 or 60%. So we try to produce ischemia by increasing demand. There are lots of ways of increasing demand on the heart, and we try to figure out if there are any blockages in your arteries. So the stress part of the test is two forms. The best form is exercise. It increases your heart rate, it causes dilation, and we get to know what your functional capacity is. Functional capacity is the best predictor of clinical outcomes. If you're able to complete a test and get to that 10th or 11th minute, the likelihood of you having an acute event like a heart attack or a stroke in the next year is just a fraction of a percent. So the best predictor of how well someone is going to do from a stress test is not really any of the other stuff, but more so how long they last on the treadmill. So that's very, very important. Vasodilation with exercise, if we strain your heart by making your heart rate go higher and higher, your arteries will dilate and more flow will get to your heart, and that's kind of how it works. So pharmacological stress testing, if you look at this here, we have two basic drugs we can use. One class is vasodilators, like adenosine, persantine, dipyridamole, other vasodilators we've used in the past. And then there's another drug called dobutamine, which basically just increases your heart rate. So neither of them, exercise does both of those, but neither of those two do what exercise does. Exercise increases your heart rate and vasodilation, whereas in the case of adenosine, it just vasodilates you, and dobutamine just increases your heart rate. So how does this cause ischemia? So if you look at this pretend artery here, you got the large branch at the top. It branches down into two medium-sized vessels. If you have a plaque, like over here on the left, and you're running around doing your day normally, those arteries or those small vessels after that plaque are already maximally vasodilated. So if we strain you or give you a vasodilator, and suddenly the other artery here that's open all of a sudden vasodilates, that will cause stealing of blood flow from the one side to the other. So blood will flow from this blocked up artery over to the newly created bed that's in the lower flow area. So the blood will automatically shuttle or shift. They call it coronary steal syndrome. Blood will automatically go to the other side, thereby producing abnormalities on the imaging part of the stress test. So that's very important to understand. It all works by vasodilation. If you have a stable plaque there, you're already maximally vasodilated distal to it. And then when we create ischemia or stress you, the other side dilates and sucks the blood away, and that causes a lack of blood flow to that one side. So imaging comes in two basic forms. The most common form is nuclear imaging. Basically, we inject you with a nuclear tracer that your heart views as oxygen. Your heart pulls this up, it's bound to, it thinks it's oxygen, and the heart muscles light up. After we stress you, we inject you with it again and see if the same areas light up. If certain areas don't light up, then we know that blood is being stolen from those areas to another area, and we call that a reversible defect. The main thing we're looking for is reversible defects, or they call it ischemia. That's the ischemia that we're looking for. The other way of doing imaging is echo. Doing an ultrasound on your heart, looking at all the walls at rest, and then making you run or speeding up your heart rate, and then rechecking the walls and seeing if any of them stop moving. If there's blood not getting somewhere, the wall will get slower and not move as well. So that's mainly what we look for with an echo. Now there are different possibilities. If you look down to this section here, you could do an exercise only stress test where you just hop on there, get an EKG, you run on the treadmill as long as you can while we monitor your EKG. There's an exercise nuclear where we make you run, we do nuclear imaging. We can do an exercise echo where you run and we do an echo on you. We could do adenosine nuclear, which is a vasodilator. Those always have to be with nuclear imaging. You can't just do vasodilation on its own. You could do dobutamine, speed up your heart rate with echo and or nuclear. So those are all the different possibilities. One thing I will say about the EKGs, you have to really look out for lead V5. Lead V5 is where you're going to see the ischemia. Now ischemia, remember, is global ST depressions. We've learned from stress testing that when someone's ischemic, the ST depressions do not localize. They don't go to just the inferior leads or just the anterior lateral leads. If somebody's truly ischemic, you'll see global ST depressions. And I will say that V5 of all the leads is the one that's the most accurate. The inferior leads actually carry the most false positives. If somebody just has inferior ST depressions, that's more likely a false positive than anything else. So that's a little bit about stress testing. Now that you know how stress testing is done, the next section, I think it's the most important, is we decide who do we stress test. How do we know which patients we should send for a stress test? If we just did a cath on somebody, can we stress them the next day or a day later or a week later when they come back? So it's very, very important. So the most important thing to do is to look at a person's pre-test probability of actually having coronary artery disease or coronary heart disease. You divide them up into three basic risk categories. You have a low risk patient, a high risk patient, and an intermediate risk patient. Now the low risk patients are these people, they're usually young people, never smoked, had a little bit of chest pain, and we're trying to, and we basically say that their chance of really having coronary disease is about 5%. Then the high percentage group, or the high risk pre-probability group, is those that we know for sure they have coronary artery disease. They've already had bypass surgery, they already had carotid endarterectomies, peripheral artery disease, they have all the risk factors. They may have even had a heart attack or two and stents. So we know without a doubt that they have coronary artery disease. The question is there anything significant or new going on? And we usually say their pretest probability is about 90%. That we know for sure they probably have something. Now let's say they've never had an MI or stroke or anything. These are your people that are morbidly obese, 60, 70 years old, hypertensive, low HDL, high LDL, smoke their whole lives, and have multiple other risk factors. Those ones, without a doubt, we could probably say have a high likelihood of having coronary artery disease. The next group is your intermediate risk patient. These are the ones with it's a flip of a coin. They may have it, they might not. They're middle age. They're between 40 to 60. They have a few risk factors. Smoked, maybe didn't really smoke a lot, but we're not really sure. Their chest pain sounds pretty real, but it's a flip of a coin. 50% chance they either have it or they don't. So those are the ones we call intermediate risk. So if we look at now our positive predictive value for a low risk patient, if you took these low risk patient people who are between 0 and 25% chance of having coronary artery disease, let's just say 5%, just to lowball it. We take a 20-year-old, put them on a treadmill, they fail, so the test is positive. If you look at the positive predictive value, it only goes up to 21%. So you go from a 5% pretest probability chance of having coronary artery disease up to 21%. So that's not very good. If you take a high-risk patient, you put them on a treadmill, this guy who's already had stents and heart attacks, his pretest probability of having coronary artery disease is 90%. A positive predictive value with the test done goes up to 98%, which is pretty good. If you go from 90% up to 98%, that's pretty good. If the test is negative, it drops to 83%. So it doesn't really help us. So if we take a patient that's high risk, we take them at 90%, it goes up to 98. If it's positive, it drops down to 83. We're still pretty sure they have coronary artery disease. So it really doesn't matter. It's kind of a waste of time to do a patient that's really high risk or high probability, I should say. So these patients, 80% chance or higher that they have it, and if you do a test and it's positive, it goes up to 98%, which we already kind of knew anyways. So it's the intermediate risk patients that you really want to test, because an intermediate risk patient is between 25 to 75%, or we said a flip of a coin right at 50%. 50% chance they have it, 50% they don't have it. So if it's positive, that 50% jumps up to 83. If this intermediate risk patient, who we weren't sure about, flip of a coin, is positive, the positive predictive value goes up to 83%. That's pretty good. If it's negative, it drops to 36%. So going from 50% down to 36%, this is a really, really good test. This test can take us from it's a flip of a coin to the 83% chance they have it or 36% chance they have it. So it's a really, really good test. It could easily rule in or rule out who has it and who doesn't. And remember, stress testing is to test for significant stable coronary artery disease. I remember one time we did a cath on a guy 2 weeks ago. Comes back in with chest pain. His coronaries were clean 2 weeks ago, and they're asking us, do you want to stress him? Well, a stress test looks for stable, significant coronary artery disease. We just did a cath on him, and it showed nothing. He had no coronary artery disease, so a stress is not going to change anything. If he had an acute plaque rupture or an acute MI, his troponin would be positive, and that's why we have troponins. But taking a person who was just cathed and was completely negative and stressing them is not going to help us, because if it's positive, he would have something. The only thing that could be positive in him would be an acute MI and acute plaque rupture. So his arteries are not going to change in 2 weeks. You don't grow atherosclerosis or plaques overnight. It takes years, like 2 to 3 years, or 4 or 5 years even. So in that case, it was kind of a waste of a question and a waste of time. There's no reason to stress anybody if they just had a cath that was perfectly clean, because you're looking for stable, significant coronary artery disease, and the cath was clean and showed that they didn't have any significant coronary artery disease. That's all for today. I hope this explains stress testing a little better. Please feel free to find me on the website or on the internet, ask me questions, or discuss this. Thank you very much, and thank you for listening.